Hello everyone, Dr. Naveen here from UPSC MEDICO. We're doing model answer discussion of test anatomy, subject wise test. So the question number 1A, it's a clinical question. So at birth, an apparently male baby has no testicles in the scrotum. Later, it is determined that both are in the abdominal cavity. So the question is for 2 marks, that is, what is the term given to this condition and explain the embryological origin of this defect. Now this question is from embryology, and yes, we have development of testes and development of ovary as a part of embryology and its associated congenital abnormalities. So among them we have a condition called cryptorchidism or hidden testis. See, one thing is clear, testis is not present in its normal position. That means there is no testis in the scrotum. Now whenever there is no testis, it can be just look here, male baby, no testicles in the scrotum and abdominal location. So it can be undescended testis, it can be cryptorchidism, or it can be ectopic testis. You can see they're asking you explain the term given to this condition. It can be any of these three things. It is important for you to understand the key differences between these three terms. The one very important term, the key term, the principal term is cryptorchidism. Crypto means hidden, orchidism means testis. That means the testis is hidden. It may be hidden, it is placed in the normal path only, but the descent is affected. That means we all know during the development, testis is abdominal. From there, through the inguinal canal, testis reaches its scrotum. So this is normal path of the testis. So if the arrest is in the normal path, instead of testis being in the scrotum, it can be suprascrotal, it can be in the inguinal region, or it can be in the abdominal region. So as per our question, they say testis is in the abdominal region. So the correct term which you can give here, what is the term given to this condition? It is undescended testis. So cryptorchidism and undescended testis are not synonymous terms. Under the umbrella of cryptorchidism, you have undescended testis. If the same testis, I am not talking about the normal path of descent. Instead of normal path of descent, it is placed somewhere else. It is going to an ectopic site, which is not normal. Ectopic site means it can be prepenile, near the penis. It can be in the inguinal, that is superficial ectopic inguinal, and also it can be in the transverse scrotal region, it can be in the femoral region, it can be in the perineal region. All these entities are ectopic testis. Ectopic testis is testis which is placed outside its normal path, and the most common location for ectopic testis is superficial inguinal perch. The other, as I already described, prepenile, perineal, femoral and transverse scrotal. So you don't have to mention all these things. Just for 2 marks, you have to kind of support your diagnosis. You can say it is a cryptorchidism because the testis is in its normal path but did not descend properly. I would like to call it as an undescended testis. Right? So this is for 2 marks, and this is you need to understand. There is one more testis called retractile testis, which also comes under category of cryptorchidism. Retractile testis is normal only, but it is because of overactive cremasteric reflex. See, in the neonates and newborns, cremasteric reflex is so active. When you stroke on the skin of the thigh, what happens? The cremasteric reflex gets activated and the testis is pulled back into the inguinal cavity. So testis can be gently milked down. The testis can be gently milked down to the base of the scrotum in this condition, and no treatment is required in this condition. No treatment is required. So one category is retractile testis, the other two which we already discussed, undescended testis and ectopic testis. Undescended testis is placed within its normal path of descent. Ectopic testis means testis is placed outside its normal path. Right? So this is first part of the discussion. Now second part is, what is the embryological origin of this defect? Now, we could see a lot of questions coming from horseshoe kidney in the congenital anomalies of the kidney. Similarly, in the future, they might ask you what is the reason behind undescended testis. But the problem with this question, undescended testis, is if you refer to any of the standard literature or textbooks, nowhere else they have given a key pathogenesis or pathophysiology behind it. There are multiple causes. We'll come back to that. First, we'll try to see what is the normal way of descent, normal steps, or at what age the descent occurs. Then we'll go to the abnormalities. You know what happens when you look at the testicular development? So testis is initially abdominal. It is at the level of T10, 11 and 12. Slowly what happens, by the third month it reaches iliac fossa. From there, in 4th to 6th month, it reaches deep inguinal ring. In the 7th month, it reaches inguinal canal. In the 8th month, it reaches superficial inguinal ring. And finally, in the 9th month, it reaches scrotum. The same thing with the help of an image: iliac fossa, deep inguinal ring, within the inguinal canal, superficial inguinal ring, and the scrotum. In 97% of the male newborns, by the birth, testis is present in the scrotum. And in most of the newborns, if it is not present within 3 months, it will come back to its normal position. If it is not happening within 3 months, it will never happen. So that's the reason the ideal time for correction is 3 months to 12 months. You have to correct undescended testis. So they say the testicular undescended testis should be treated before 12 months of age. 3 months to 12 months is the ideal time. Before 12 months, it should be corrected, because if you delay it, there are more chances or there are more complications. We'll discuss about that. For time being, what is more important is the timeline, and I had seen in the many PG entrance examinations, they are asking you, testis is lying at the level of inguinal canal. What could be the age? It is 7th month. At the age of 7th month, fetal age, you will see it lying at the inguinal canal. Okay, it is intrauterine age. Okay, this is intrauterine age. Now, what is the embryological origin? You know the pathways of the descent, how it all happens. Now, let's look at the embryological origin. Now, there are multiple risk factors. If you see a kid, if you see a newborn with undescended testes, there are risk factors like prematurity, low birth weight, and also disorders of sexual development, that is hypospadias, congenital adrenal hyperplasia, androgen insensitivity syndrome, and also sometimes there is family history also. Okay, in the sibling you will see it. Okay, in the twins and siblings you might see it. So what is undescended testis? It is arrest in some part of its normal path to the scrotum, and undescended testis is more common on the right side than left side, whereas varicocele is more common on the left side than the right side. Just an extra point. And most of the times, 20% of the times, undescended testes are bilateral. Now, if I want to write about the pathophysiology, you need to understand our embryological origin or pathophysiology. You need to understand how the descent actually occurs. You know what happens? Look at this image. We all know testis develops in the retroperitoneal region at the level of T10, T11, T12, as I seen here. See, T11, T10. This is retroperitoneal testis. Slowly, what happens? At the 7th week, or probably at the second month, during second month, there is formation of a special structures called gubernaculum. Please, this term is very important for this answer. You see gubernaculum, which is attaching to the testis, and it is also attaching, so the upper end is attaching to the developed testis and lower end is attached to the abdominal muscle walls. Okay, this is gubernaculum. At the same time, the peritoneum is also forming. The peritoneum, you see, the peritoneal region or the peritoneum is also forming, see, vaginal process or processus vaginalis. You have gubernaculum, you have processus vaginalis. What happens? Slowly the testis is descending into the scrotum, and along with it, it is carrying the processus vaginalis and gubernaculum. And once the testis reaches the scrotum shortly after birth, you will see processus vaginalis forming into tunica vaginalis. It has parietal and visceral layer, and you also see some gubernaculum testis attached to it. So the two important structures which are important in descent of testis are, one is development of gubernaculum and other is development of processus vaginalis. So whenever there is gubernacular abnormalities, you see undescended testis. Similarly, change in intra-abdominal pressure also plays an important role. So any intra-abdominal pressure, if it is reduced, it might not help the descent of the testis, the other pathophysiological factor. And imperfectly developed testis will not descend. This is the dictum. Imperfectly developed testis, they descend poorly. So any intrinsic testicular or epididymal abnormalities also, testicular abnormalities, you will see, in case of testicular abnormalities, you will see failure of the descent. And very importantly, endocrine abnormalities are important, because the two hormones which are very important in descent of the testis are Mullerian inhibiting substance or anti-Mullerian hormone, and also maternal beta HCG. These two are important hormones. Along with that, we have endocrine abnormalities or disorders of the sexual development, that is hypospadias, congenital adrenal hyperplasia, and androgen insensitivity syndrome. They all predispose to undescended testis. Right? So these are all the pathophysiological factors or embryological origin of undescended testis. Now, how do you investigate? See, most of the times the diagnosis is clinical, but you can confirm it with ultrasound, and in some cases you might need to go for laparoscopy. Okay, and we all know the treatment. It is orchidopexy. It should be done within 1 year, less than 1 year of age. And one important thing I expect in this answer is try to mention clinical implications. See, it's very important. Undescended testis is associated with four key complications. Undescended testis has chances of developing testicular malignancy, and most common testicular malignancy is seminoma. One more problem is the testes which are undescended, they undergo atrophy, and in turn they predispose to infertility. And one clinical point I want to tell you, I had seen many PG related questions in this point. If we do orchidopexy less than 1 year of age, there is no study which says that by doing orchidopexy you can reduce the incidence of complications. No, the risk of complications remains same even if you do orchidopexy or if you do not do orchidopexy. The only advantage of fixing this issue is, if at all there is development of seminoma, then you can easily identify it if the testis is extra-abdominal. If it stays in the abdominal, you might not detect a testicular cancer. It might metastasize, leading to the mortality, right? So that's a major advantage. So there is no reduction in risk of any of these complications, but definitely the torsion risk can be reduced, because abdominal, because of the fibrous cord, the more chances of torsion, and also hernia chances can be reduced, but not seminoma or infertility, right? So this will kind of conclude our discussion on the first question, that is undescended testis and its embryological origin.